Yes, so it's my great pleasure to introduce Nuria Oliver. I've been lucky to run into her several times over the last few years, of course, virtually and not in person. And unfortunately, we'll have to be virtual again this time around. But I'm so grateful that you're able to come and speak with us today. Nuria Oliver is the co-founder and vice president of ELIS, the European Laboratory for Learning and Intelligent Systems, and the co-founder and director of the Institute for Humanity-Centric AI, ELIS Alicante. And she's a chief data scientist at Datapop Alliance and chief scientific advisor to the Vodafone Institute. She used to be local. She got her PhD at MIT, not far from here. And she has innumerable awards. She's an elect member of the Royal Academy of Engineering, a fellow of the ACM, IEEE, and NeurAI. And it's just really wonderful to have her here to talk to us today about the Institute of Humanity-Centric Artificial Intelligence. We've talked a lot in this conference about making an impact and living out our values. And I think she's done a wonderful job of showing one way through which this can be done. So with that, I'll hand it over to you, Nuria.
Thank you. Thank you so much. Good morning, everyone. It's a great pleasure to be here, even if just digitally. I was excited about traveling to Boston, and due to COVID, I couldn't actually travel. So I'm really sorry about this. In my presentation, I will briefly share with you a little bit more information about ELIS and ELIS Alicante, which is what I was kind of supposed to be doing at the end and the very beginning, at the end of 2019, very beginning of 2020. But then, of course, COVID-19 happened, and I'll mostly explain to you what we've done in the context of COVID-19. So I created at the beginning of 2020 this institute called the Institute of Humanity-Centric AI, and it's part of ELIS, which is a network of scientific excellence on AI in Europe, and it means the European Laboratory for Learning and Intelligent Systems. And the main goal for ELIS is to attract and enable the best talent to come to Europe and to do research in AI in Europe. ELIS has distributed vision. So the idea is not to attract everyone to the same location, but to enable different regions to attract the talent and then develop really strong regional ecosystems with startups and companies and academia and institutions and governments around this excellent talent that we want to attract. And then, of course, none of these regions will be very meaningful, probably on a global scale. So ELIS connects them all on a network to have the size to really have an impact in the world. ELIS has 4 pillars. I don't have the time to explain them all. And vice president and co-founder of ELIS, the president is Perhash Sholkov, whom you probably know. And the 4 pillars are the ELIS research programs, which bring together the top scientists, mostly in Europe, but occasionally from out of Europe, but with links to Europe, working on different themes. I am co-director of a program on human-centric machine learning. These programs organize workshops, and they bring together the top scientists in Europe that are working on the topic of the program. ELIS has a very strong PhD program, and this has funding from the European Commission. The goal is to identify the best talent in the world to come to Europe to do their PhD and work with all these distinguished scientists that are part of the ELIS research programs. There are 2 labels actually in ELIS: ELIS Fellow, which is a distinguished senior scientist, and ELIS Scholar, which is a distinguished junior scientist. The ELIS PhD program is in the 2nd class right now, which they will start in the fall of 2022. The first class that started in the fall of 2021 was quite selective. There were around 1,400 applications, and I think there were 60 students that were selected. The 3rd pillar in ELIS is the ELIS units and the ELIS institutes. Ultimately, ELIS wants to create a network of institutes, but that would require a lot of intergovernmental organization and investment. So in the meanwhile, there is the ELIS unit, and an ELIS unit is basically a team, a research group that has certain criteria in terms of scientific excellence, but also that commits to sort of like changing the way research is done in Europe to be more attractive for excellent talent. And then finally, ELIS has the fourth pillar, which is the relationships with other institutions, the European Commission, companies, startups, and so forth. In this context, there's been 4 competitive calls for the creation of ELIS units. And out of those calls, there is 34 ELIS units right now, most of them are in sort of like the center and the north of Europe. And one of them is the ELIS unit in Alicante that I co-created. As you can see on the map, most of the units are in the top places to do research in AI. So a couple of Max Planck Institutes, ETH Zurich, EPFL, Oxford, Cambridge, the Technion, etc. The ELIS unit in Alicante could only really start officially in October of 2021, so at the end of the pandemic. And it is the only unit that has a clear focus on using and investigating and doing research on AI for social good. It also has sort of like a science startup culture, because it's a newly created foundation. So it's the only ELIS unit that actually has a legal entity behind. It has a private public funding model. It was created with the support of the Valencian government, but it also has private funding. And the idea is to change the way research is done when compared to the traditional way of doing research in Europe. So the idea is to be a lot more agile, a lot completely intellectually free, focused on sort of like purpose-driven research, fundamental research, non-bureaucratic, and very collaborative. We work on 3 areas, which we call AI to understand us, AI that interacts with us, and AI that we trust. I don't have the time to explain the projects that we're doing on these areas, but basically, when all of this was being created in January of 2020, the COVID-19 pandemic, started. In the first area, as you can see on the slide, we have a focus on using AI for social good and for sustainable development. And since 2008, I had actually been working on that topic. So when the pandemic started in March of 2020, I felt compelled to reach out to politicians and decision makers with the idea of creating a team of scientists working very closely with the policymakers to support them in their decision making throughout the pandemic, because I felt that there was so much knowledge and so much research and so many models that could be used, and I feared that they weren't going to be used. So I guess I was successful on my pitch, and very quickly, within a few days, the Presidency of the Valencian Government created a task force called the Data Science Against COVID-19 Task Force that I've been leading for 2 years, working on how to use data and AI to support their policymaking. So the main sort of like core of my talk is sharing with you the work that we have been doing in the context of this task force. But I just wanted to give a little bit of context of what ELIS is. And actually related to this, before I move on to the other topic, I wanted to mention, because it's probably of interest to some of you, that in the ELIS unit in Alicante, we have a human-centric machine learning reading group, which is international and online. And in case you are interested in joining, it's open to anyone. It meets every 2 weeks, and the way of working is sort of like choosing different papers and discussing the papers. And the papers are quite diverse, from theoretical papers to more societal papers and so forth. And the other piece of news that I wanted to share with you is that we are organizing the ELIS Doctoral Symposium between September 19th and September 23rd. This symposium is targeted to the ELIS PhD students that are all over Europe, but it's also open to other PhD students or scientists. So if you are interested in coming to Spain and joining the symposium, you're welcome to do so. The theme of the symposium is AI for social good, because we are organizing the symposium, but this is mostly reflected in the keynote speakers and the panel on fairness. The content of the posters of all the students is very diverse, covering all the areas of machine learning and sort of like data-driven kind of like AI. So now going back to the topic, of the data science, which was the main topic of my talk. As I explained, In March of 2020, I pitched to the president of the region to create this team, and the response was quite positive. And very quickly, we created this sort of like virtual team, because of course we were in March of 2020, we were fully confined, very beginning of the pandemic, of 20 something scientists from the different universities and research centers in the Valencian region of Spain, which is where Alicante is based. This is on the east of Spain by the Mediterranean Sea. You can see here the map of the region. And they officially called us the Data Science Against COVID-19 Task Force. And our purpose was to support the decisions that the government was going to be making related to the pandemic by helping them have those decisions be based on evidence and science. The main challenge was to fill the gap that there is between where the data is, if we think that the data is a reflection of an underlying reality, and where the policymakers are. And filling that gap is been traditionally hard, and it is still, I think, a challenge. So the way we structured our work was on 4 different work streams. The first one was large-scale human mobility analysis, because of course, an infectious disease that is transmitted from human to human, like coronavirus, doesn't become a pandemic if people don't move. So modeling and understanding human mobility is very important. So that was our first work group. The second work group was on building computational epidemiological models to predict the number of COVID-19 cases daily, not only under the current situation, but also under any possible scenario of confinement measures or what is called non-pharmaceutical interventions. The third work stream was on building predictive models, mostly of healthcare impact, so hospital occupancy, intensive care occupancy, but we also built very early on, when there were no PCRs, a prevalence model that could infer the prevalence of COVID-19 in a situation where there was an absence of tests. And finally, we launched a very large-scale citizen survey called the COVID-19 Impact Survey, because we wanted to understand the impact of the pandemic on people's lives. Even with all these different areas, there is still a gap between all this work, which is still quite technical, and where the policymakers are. And I'm pretty convinced that one of the reasons why our team has been successful is because of this layer here of results interpretation, aggregation, and translation from scientific language to political and actionable language. And this layer was mostly composed of a politician, a director general working for the president together with me. And she is an active member of the team. She came to every meeting, and we actually met every day for many, many months. So I think to really have impact in this context is absolutely necessary to have multidisciplinary, multi-institutional teams where not only the scientists, but the decision makers are very active members of the teams, and they really believe, in the work that is happening. In terms of the technical skills, everyone was a scientist with a variety of skills, all within sort of like data science, machine learning, statistics, human-computer interaction, epidemiology, and so forth. We worked with.
Sorry, I just had a question. Oh, just a question, Nuria. I was curious about your team. So you said it was an interdisciplinary team. How much coming into it, did everyone have some amount of technical background, or did you kind of build that translation as you went along? Like, can you tell us a little bit more about that process? Because I agree that gap is so tricky.
Yeah, so everyone was quite technical. This is a picture of one of our meetings, but this is, for example, the data protection officer of the government. This is the director general in the government. So I would say most of the team was of a scientific background of different areas within a somewhat scientific background, but we had very intense, very close daily, multiple times a day interactions with the policymakers and the members of the government. In parallel, the president, a little bit later on, I don't think it was exactly in March of 2020, maybe it was, I can remember, a couple of months later, the president established another broad advisory team that was extremely multidisciplinary, where there were historians, economists, psychologists, psychiatrists, public health experts, clinicians, all sorts of people. And I was a member also of that team. That team was definitely not like our team in terms of the intensity. We met every week, but it was also very helpful for our team, because I was in every meeting, I was sharing the latest summary of the results of what we have done that week. And because it was so multidisciplinary, we got a lot of feedback and questions that really helped us do this translation exercise, which is non-trivial. We were also quite firm in our in what we believed in. So I remember that when the first wave of infections went down, I guess it was around May of 2020, or yeah, end of April probably. The president wanted to give a speech to make a prediction when there would be 0 cases. And we told them, you're not going to be able to say that. The virus is going to be here. And once you lift the restrictions, there will be another wave because we haven't reached herd immunity. And there was a lot of going back and forth to really transmit that message and really make them understand that that was the case. And I guess we were successful because they never made any kind of a statement saying, oh, we defeated the virus, or oh, there will be 0 cases or anything like this. The message was always more like, this virus is coexisting with us, and we just need to figure out a way to mitigate the impact that it's having in our lives, and to really protect particularly the most vulnerable and so forth. But if you don't have that level of involvement, and if you don't have the politicians really believing in the work, I think it's very difficult to have sustained, impact. And I think that's one of the reasons maybe our team was special, because we were lucky to find the connection with the government side and identify individuals that were really passionate about this and that were really willing to make the effort. And it was a big effort in a situation where there were hundreds of decisions that they had to be making every day. So they also prioritized this over many other things that they had to be doing, and they found the time to devote it to our effort. And I think that was really critical. We have an official website, but it's not in English, it's in Spanish and Valencian, in case anyone speaks the language. And it's not easy to create a team like our team. So because I had experience from the past in similar efforts together with a lot of scientists, we wrote this article for Science Advances where we quite early in the pandemic in April of 2020, where we really pitched, but in a realistic way, the value that data could have, and particularly mobile data, to inform public health actions, throughout the entire life cycle of the pandemic. Some of the challenges that I think are common in creating teams like this, the first one, which I think has been quite global, is the lack of capacity, the lack of awareness, and the lack of digital mindsets in most governments and public administrations. There is also challenges related to accessing the data, because in many cases the data is very siloed, it's in different places, and of course the reality is like the same. You have to be able to figure out how to combine or access different data sources. There is obviously concerns about privacy and data protection. We ended up using only data that was almost 100% publicly available and always fully aggregated and anonymized. There is a gap between where research ends and where the real world, I guess, starts. And closing that gap is not easy. And then, of course, if you don't have all these elements already in place, and then a pandemic hits you, it's not that you have time then to say, oh, I'm going to digitize now my administration so I can make data-driven decisions for the pandemic, because you have to be making decisions constantly every day. You obviously don't have the time. So there's also this issue of the time pressure, that if you didn't have the components, it was very difficult to be able to build them, during the pandemic. So I'll give you a summary of some of the things that we've done in each of the areas, starting with the mobile data analysis. So as I mentioned, the main purpose for this analysis, I guess, was twofold. First, to really understand the impact of the non-pharmaceutical interventions on mobility. And secondly, determine whether that impact on mobility was enough to contain the pandemic. Also, for public policy making in our in all of Spain, but particularly in our region, the spatial granularity that was meaningful many times were the health departments, which are the regions that are served by one hospital. There are 24 health departments in our region. Spain has a universal free healthcare system, so these are all the big public hospitals. This is a visualization of the mobility that we analyzed early on the pandemic. So this data was shared with us through the National Office of Statistics, and it was large-scale anonymized mobility data that was derived from the 3 largest telcos in Spain that were sharing the data with the National Office of Statistics. Later on, that data was made public in the summer of 2020, but we were appointed by the Vice President of Spain, Calviño, the pilot region, to be able to access the data since March of 2020. One of the first analyses that we did was the impact of the stay-at-home campaign. And we had one of the most severe confinements in Europe in Spain, between starting in March 16th, but particularly during the, I guess, first 2 weeks of April, where we didn't even have labor mobility. So here what I show on the map is for each of the areas that it was the smallest granularity for our data, which are these irregularly shaped areas, the percentage of people that that area was their area of residence, so they slept there and they never left that area for more than 2 hours during the day. And what you can see on the map is that it's all very green, meaning that more than 85% or even 90% of the people sleeping in those areas left the areas during the day. So when we look at the statistics, we find that during working days, 88% of the people didn't leave their residence area, and during weekends, 92% of the people during the first confinement. So there was a very high levels of compliance of this stay-at-home campaign, understanding the home as the area of residence, not the physical home, because we didn't have that level of spatial granularity. This is a visualization of the same type for the entire first wave of the pandemic. This was the first day that Spain declared a state of emergency, March 19th. As you can see, there are still some yellow and orange parts, meaning there was a certain amount of mobility outside of the area of residence. Sundays are always the days with the least amount of mobility. And as you can see, they are always quite green on the map. And then starting the first 2 weeks of April, we didn't have labor mobility. And that's why the map becomes a lot greener. So from that perspective, the non-pharmaceutical interventions did indeed really impact the mobility. We always did the same analysis at the health department level. So these are the 24 health departments in the Valencian region of Spain. And you see the percentage of people in their area of residence during weekdays, which is the kind of maroon color, and then in weekends, which is this brownish color. As you can see, all of them had at least 80% of the people never left their area of residence, some of them reaching almost like 100% of the people. We also studied the impact of the non-pharmaceutical interventions on labor mobility. To do this, we had a reference week in November of 2019, so we could compare the labor mobility between the confinement period and November of 2019. And we found that on average, there were 60% fewer people outside of their area of residence during working hours during the confinement when compared to a day in November 19th. We also focused a lot on visualizations and creating tools that the policymakers could use. So we created this tool where you could click on any municipality and the tool would show you the incoming mobility, the outgoing mobility, the percentage of people that stayed at home, the evolution over time. You could select the time period. So the policymakers could determine if there were municipalities where the non-pharmaceutical interventions were not working or they were behaving in a different way. because we had the flows between the different areas, we could also identify mobility communities, which would be regions in space that had a lot of inner mobility, but didn't have a lot of mobility to other areas. Running a community detection algorithm, we identified 14 different areas, which we call macro health zones. And we thought that that was valuable for the government, because if they wanted to do partial confinements, it's helpful to know when you're implementing a partial confinement, how much cross mobility there is between the potentially confined area and other areas, or if it is really self-contained. The second work stream focused on computational epidemiological models. So predicting how many cases, there's gonna be in the future. First, we built 3 different kinds of models, and we run predictions using the models. So that's another, I think, a strategy that we followed that was quite helpful, which was to have models of different nature modeling the same underlying reality, because the models, they all have their strengths and their weaknesses, and that gave us more robustness in the quality of the predictions. The first model that we built is a traditional SAIR metapopulation compartmental model. If you are familiar with computational epidemiology, you probably know this model. So you divide the population into metapopulations that can be in 4 different states. Initially, everyone is susceptible because we assume that we hadn't been exposed to SARS-CoV-2 before. With a certain probability, people can be exposed to the virus. With a certain probability, they become infectious and they infect other people and infected. And then with a certain probability, they are retired from the system because they either recover or they die. These probabilities had been estimated early on the pandemic with data from China fundamentally, and we adjusted the parameters so they would actually work for the Valencian region. And we also included the mobility information that we had, and this is a visualization of like the predictions of our model and the ground truth data in red, throughout like many months of the pandemic. To have more flexibility and also to have a different approach, we also built an agent-based epidemiological model. In this case, you don't model metapopulations, you model every individual, so 5 million people, and you have the demographics of the population, their age, their gender, and also some contact matrix that tells you a little bit about their behavior. And they can also be in these different states, susceptible, exposed, infectious, infected, or recovered. And then you can run simulations with this model. So we use the REINA framework to create the agent-based epidemiological model for the Valencian region. And with this model, we had predictions on the number of cases, the number of hospitalizations, intensive care, unit occupancy, and deaths. And finally, in the fall of 2020, I received an advertisement for this challenge called the XPRIZE Pandemic Response Challenge. And mostly joking, actually, I told the team, hey, maybe we should run for this challenge. But it was a completely different level from what we were doing, because we had been doing a huge amount of work, but always focusing on the Valencian region of Spain, maybe in Spain, but not like thinking, about the entire planet. And this was a kind of like a planetary challenge. Some people in the team were very enthusiastic and they said, yes, let's go for it. So we kind of like a subset of us decided to go for it. And we called ourselves the Valencia IA for COVID-19 team. And it was really a bigger challenge than what we had been working on, because the first phase of the challenge, we had to build computational epidemiological models for 236 countries and regions in the world that should be able to predict the number of COVID-19 cases up to 180 days into the future, and taking into account the different non-pharmaceutical interventions that were implemented in each of these regions and countries. So we decided to go for a deep learning based model, and we had 2 layers. We had a layer that was modeling the cases and a layer that was modeling the non-pharmaceutical interventions. And because of the diversity of dynamics in the different countries and regions in the world, we actually developed a bank of LSTMs that would be able to capture like sort of like, we were able to cluster the world into like different types of dynamics in terms of the COVID-19 cases. And then these models were modeling the different regions or countries in the world. The model actually worked pretty well during the competition. I think we were the third best in the world in terms of mean rank, and the first in Europe, European countries and Asian countries. But the most important thing is that we finished that model in December of 2020, and Spain, and particularly the Valencian region, suffered the worst wave of infections right after Christmas at the beginning of 2021. And you can see here in this graph, the ground truth, which is this yellow line, the blue, which is the predictions of our model, and the red, which is the predictions of another state-of-the-art model. And you can see our model worked really well and actually helped a lot the government understand when we were going to reach the peak and how large that peak was going to be, because there was a lot of pressure in the healthcare system at the time. It was really a very stressful set of like a couple of weeks. In 2021, we worked on adding vaccination to the model, and this is an example of the last wave, which was right after Christmas of 2021. So at the beginning of 2022, the yellow line is the ground truth, the red line is the predictions of our model, and the green line is the predictions of another state-of-the-art model. So our model, again, predicted really well the peak of the infection and the magnitude of the peak. Part of the XPRIZE competition involved building a prescriptor of interventions, or what I call an artificial politician. So that was the final phase of the challenge. So what they wanted us to do was to make a system that would propose 10 different public policies that would have the best trade-off between the cost of those policies and the number of COVID-19 cases that would result if you were to apply the policies. That is, that would be the policies that would be on the Pareto front of this two-dimensional space. So we followed different approaches to try to identify this Pareto front, because we had computational limitations in the challenge. We couldn't take more than a certain number of hours to achieve this. It's a pretty complex problem. And we also built a visualization so the policymakers could use our system. So this is an example. You click in Spain, and then you could see all the different policies. Each of these dots is a policy. And these, the axes are on the x-axis is the stringency, which is the cost of the policies. And on the y-axis will be the predicted number of cases. There is always two extremes. The extreme where you don't do anything. So it's like, in terms of economic cost, maybe zero in the short term, but then you get a lot of cases. And the other extreme, which is you implement every possible non-pharmaceutical intervention out there, and then it might cost you a lot, but then you have a much fewer number of cases. And in between, so there is this Pareto front. And we were able to develop this system. And a little bit to our surprise, we ended up being the winners of this World Challenge. So it's a very nice experience for me, because I think it's the first time that a Spanish team wins an XPRIZE competition, and it really motivated everyone in the team to realize that there is talent everywhere, and that sometimes what we fail is in finding the right environment for this talent to flourish and the right purpose for the talent to really be motivated, because we had been working really, really hard for like 6 months prior to the challenge, but then during the challenge, we worked even harder. We had a couple of papers, so we won Best Paper Award in the Applied Data Science track in ECML-PKDD, and we were invited to submit and present the work in HCI now in a few weeks in Vienna. After the first wave of infections, when we were entering what is called the TTI control strategy, which is test, trace, isolate strategy, there was a huge amount of dependency on the ability to contact trace. So we also ran simulations with the models on the impact of contact tracing. And according to our models, we didn't have to contact trace every single individual to be able to flatten the curve, but that was assuming that every infected individual could self-isolate. And we knew from the citizen survey that that was not the case, as I will explain later. So we communicated many, many times for many, many months to the government that there were a lot of difficulties with self-isolation. And it didn't help to identify all these positive cases if they were going to work, the next day, or they couldn't self-isolate because they're going to infect, everybody else. We also added vaccination both to the agent-based model and to the deep learning-based model. In terms of predictive models, we focused on predicting hospital occupancy and intensive care occupancy, doing it at the health department level. So for each hospital, so the hospitals could anticipate how many patients due to COVID and overall would have, and how many intensive care patients due to COVID and overall they will also have. And we built different models, including also recurrent neural networks-based LSTM-based models. And finally, we deployed this citizen survey. And the main reason why we deployed the survey was because since March of 2020, we had so many questions about people's behavior and the impact of the pandemic on people's lives, and we couldn't answer them because we didn't have any data source. So we thought, okay, let's just reach out to the people. It's also a nice way to give voice to people, because in this pandemic, everything is happening to us, but we don't seem to have a voice. So maybe this survey will be a tool for people to really express themselves and share back, what is going on with their lives. So there were important questions that we wanted to answer, such as what is the social contact behavior? What's the economic and labor impact of the pandemic? What's the resilience of the population towards these non-pharmaceutical interventions and these very severe confinements? What's the prevalence of symptoms? Could we infer the prevalence of the disease because there was no testing at the beginning? What's the emotional impact? What kind of protection measures people adopt? Is contact tracing working or not? So all these questions we wanted to answer. So we launched this anonymous online survey at the end of March of 2020. Very simple, 26 questions translated to many different languages. We got a huge response. In the first 40 hours, we collected 140,000 answers. It actually was making the servers go down from the volume of answers. And that really impacted us in a very positive way, but also we felt a huge responsibility. So we very quickly, in just a few days, analyzed all the data, wrote a paper, shared the data, and shared all the insights that we had obtained, which actually applied almost for the entire pandemic. The same insights applied. We also built 2 visualizations that were publicly available using Esri and using Tableau, and we kept updating, particularly the Tableau visualization, like every few days. So not only the policymakers, but people, the media, anyone interested could actually look at the data. We've done a lot of different studies and published different papers understanding different elements of the impact of the pandemic on people's lives. I just wanted to share with you some of our findings. So the first finding, which has been extremely consistent for the 2 years of pandemic, is in terms of the emotional impact. And we find that the most impacted demographic group is the youth, 18 to 29 years old, and particularly women. We found that young females, more than half of them reported stress levels and anxiety levels that they consider detrimental to their health. But even loneliness was the largest among the youth. So since the very beginning of the pandemic, since April of 2020, one of our recommendations was to develop mental health support and emotional support programs for the youth. We also wanted to know what was the perception of people to the government measures. And we had a question on whether people considered the measures were not enough, which would be the yellow line. The measures were enough, which is the green line, or they were excessive, which would be the red line. So as you see in Spain, the general sentiment was that they should do more. And these peaks that you see on the yellow line coincide with the peaks of the pandemic. So whenever the cases were growing, then everyone will want more measures. In terms of the individual protection measures, this is recent data, but some of the patterns are the same since the beginning of the pandemic. The first finding that is interesting is women. Throughout the entire pandemic, we have been more compliant with the protection measures than men. Washing hands, wearing disinfecting hands, wearing face masks, avoiding crowds. It's always like the female respondents that are a lot more compliant than the male respondents. The female here are marked in red and the male are marked in blue. We also found that the measure in Spain that was the most popular was vaccination. Spain had a huge percentage of willingness to get vaccinated. This is very late data where the population was already double or triple vaccinated, and still there was a huge intention to get vaccinated, but that percentage is actually lower than at the beginning of the vaccination campaign. Like say in the late spring of 2020, we were in 93% or so on average of people wanted to get vaccinated. Another also recurrent results throughout the entire pandemic is that ensuring indoor ventilation is like the least popular measure, even though it's one of the most important measures. So that was another recommendation that we share systematically with the government, encouraging them to do communication campaigns to really emphasize the importance of indoor ventilation. When we look at the perception of risk of different activities in terms of risk of getting COVID-19, we find quite consistent patterns throughout the entire pandemic. So first of all, doing sports individually, outdoors was the activity that everyone considered the safest in terms of risk of COVID-19, which made a lot of sense because if you're alone outdoors, I don't know how you're gonna get COVID-19. On the other end, the least safe activity that everyone thought throughout the entire pandemic is this blue line here, which is flying by plane. So this is also very peculiar because there aren't a lot of outbreaks, recorded outbreaks, in flying by planes, and the planes have a very expensive, good filters and so forth. But still, throughout the entire pandemic, people thought that flying by plane was the least safe. And then we find some activities like going to the beach that are extremely seasonal. So in the winter, people thought that going to the beach wasn't very safe, but then suddenly in the summer months, everyone started thinking that going to the beach was safe. So I think there's a fair correlation between what people do and what activities they think are safe or not. When looking at the ability to self-isolate, which was very important in the TTI.
I'm just curious, one question, going back to your slide in terms of what people thought were safe. Does this roughly correlate to what is actually safe? Or are people way off?
No, I don't think it's correlated. That's what I'm saying. I mean, going to the beach is like an outdoor environment. If you are alone, I don't necessarily see this is less safe than being outdoors somewhere else. And for example, it's also very interesting that people thought that having like friends in your house, was safer than some like flying by plane, for example. Or I don't think there is necessarily a factual correlation between the perception and the reality. I think it's more related to what the activities that people did, because if you do it, you tell to yourself that it must be safe. So I think there might be a component of, I'm doing it, so probably it's safe, because it's very peculiar that in the summer when everyone goes to the beach in Spain, they think it's safe, but then in the winter, somehow they think it's not safe, and it's the same beach, and it's actually emptier in the winter. There's not that many people on the beach. It's also like schools is another interesting one, is this pink one here. So schools started with very low perception of safety. So it was below 10% of people that thought that going to school was safe in May of 2020. The perception of safety increased, but as you can see, it never really went above 45%, even though in Spain, schools functioned, particularly primary schools and the early years of secondary schools, they functioned fully since September of 2020, like a normal school year. We didn't have online learning because they thought that the damage of having children in their homes, in many cases, possibly by themselves, many cases possibly without an internet access, or was more detrimental than the risk of COVID-19, given that they had ventilations in all the classrooms, they had filters in all the classrooms, they had reduced the classroom size, and everyone was wearing masks. So still the children were all going to school, but somehow the population didn't think that it was that safe, and we didn't have that many outbreaks in schools at all. So I'm not sure, I don't know, it's like the general sentiment of safety is, there was also another anecdotal finding, given that you're asking me, which is hairdressers. So which is this green line here. So there was a very significant gender difference in hairdressers. So in general, women tend to be more conservative than men in their perception of risk. So women tended to rate all the activities as higher risks than men, all of them, except for going to the hairdresser, where women thought it was safer than men. So it's very peculiar because it really correlates with what you do, right? And we had huge amounts of data. I mean, this is almost 400,000, so it's a massive sample, and it's a very rich sample. We actually have a Fulbright Innovation Award winner coming between January and June of 2023 to actually work with us on some of these, because the data is so rich and there are so many interesting questions that we could ask, and answer analyzing this data. In terms of isolation, one of the most consistent findings is roughly 50% of the people aged 59 and younger reported not being able to self-isolate. The main reason is because sharing their home. But there are demographic, both gender and age differences that have been very consistent throughout the pandemic. The first one is the psychological reasons. The youth was by far the most likely demographic group to report that they would not be able to self-isolate because it was psychologically impossible for them, or because of fear of stigmatization. And we saw the fear of stigmatization increase throughout the first year of the pandemic a lot. So we also provided a lot of recommendations in terms of this fear of stigmatization in the youth, and how it was important to deploy communication campaigns to really address that. And we also find gender differences that corroborate the differential burden in childcare between men and women. When we look at the reasons not to be able to self-isolate due to childcare, we find that it is women that are aged 30 to 59, which is the prime time in Spain for having children. We find that they are significantly more likely to say that they wouldn't be able to self-isolate because of childcare when compared to men of the same age, even though presumably those children, those are the fathers of those children. So we really saw very significant gender differences in different elements of the impact of the pandemic that really brought to the surface a lot of the differential burden that women carry in Spain versus men, in more like the domestic sphere, or even in the workspace where more women were working part-time, for example, than men, and things like that. And finally, we wanted to know whether the contact tracing app was working. And we actually didn't have any evidence that this contact tracing app did anything in Spain. So this is an example of a large sample. So out of 140,000 people, roughly a third, 30% reported having the app. So it was very high adoption. Out of those, 3,200 reported that they had been in contact with a positive case, like they knew they had been in contact with a positive case. However, out of those 3,241, only 86 discovered it because of the app, of which only 27 got tested. So there's a huge drop even in getting tested, of which only 7 tested positive. So from this original sample of 139,000 people, the app helped identify 7 positive cases. So it's a very small impact that we found in the case of Spain. And some of the most recent work that we have done is in terms of social isolation. We felt that a hidden pandemic was the pandemic of social isolation. So in the summer of 2021, in June of 2021, we added 6 questions to the survey, which are the questions of the short Lubin social isolation scale. And we have one of the largest samples probably in the world of social isolation in the general population. And we found really worrisome results, finding a prevalence of social isolation of roughly a fourth, like 24-25% of the population. That's a very high prevalence of social isolation. And those levels were going up to 30% among the middle age, between 40 and 59 years old. So we also found that the most socially isolated individuals are actually the ones in the middle age. It wasn't the youth, but also it wasn't the elderly. In terms of economic impact and psychological impact, we find that those that had severe economic and psychological impact were in a higher risk of social isolation than the ones that not, which is, I guess, quite intuitive. And we have it's a very long piece of work, and I don't have the time to explain it all, but I thought it could also be interesting to you. So after all these 2 years of work, what have we learned? So one of the most basic things that we have learned is that a pandemic is not a public health challenge, it's a societal challenge. And it really requires a holistic approach and a multidisciplinary, multi-institutional approach to really understand the complexity of it and to really tackle it, from this multidimensional perspective. We also found that there is this missed opportunity of finding this virtuous cycle between data, people and technology, and public policies and processes. Data that would need to be systematically captured and analyzed to understand where we are, why we are where we are, but also predict maybe where we might be going. People, the right amounts of people, but also empowered with the right technology. At some point, there were contact tracers using a technology from the 1970s or something. It would take them like an hour to enter a case. That's obviously not scalable. So I think it's fundamental to invest in this combination, of people and technology. And of course, all of this is to really inform public policies or to measure the impact of these public policies. So we really need to close the loop. During 2020, I also co-wrote this public policy article together with Data Pop Alliance and the Vodafone Institute, where we discussed this interplay between data, technology, and the pandemic. And we sort of like formulate some recommendations, to move forward and to be better prepared, next time. We have a lot of publications, as I mentioned a little bit throughout my talk, and we have given a lot of talks and media coverage, in all sorts of media, because we felt that it was very important to share sort of like rigorous information about the pandemic to mitigate, the impact of like fake, information. And that's all I have the time to share with you. So thank you very, very much. And again, sorry that I cannot be there in person.
Thank you.